Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Good evening, one and all. I welcome you all to today's Navigate Medico CME program. Now I would like to invite Professor Umesh Kapil Sir, the Secretary of National Academy of Medical Sciences, to deliver his welcome address.
Good evening to all. Thank you, Dr. Preeti. We have, on behalf of National Academy of Medical Sciences, I welcome all the participants. I welcome the speaker of the day, Dr. Anu Gupta, who is working as an assistant professor in Department of Neurology at All India Institute of Medical Sciences, New Delhi. Anuji, we are most grateful to you for your kind presence and your acceptance to deliver this Navigate program. This Navigate program we started by NAMS, keeping in view to update the knowledge of the postgraduates who are working in the field of neurology, and with the aim that we can have the most eminent faculty members who have developed the expertise in a particular area, and they can develop the youngsters who are working in the field of neurology. The theme of this Navigate program is effective management of common neurological diseases. We have covered earlier the approach to Parkinsonian syndrome, and this was done by Dr. Rupa Ranjan. And we have an excellent coordinator, the chief coordinator, Dr. Padma Srivastav, who is the head of the Department of Neurology at AIIMS New Delhi. Personally speaking, I find all these presentations extremely useful. We have these presentations on the website of NAMS, so that those who have missed the opportunity can go to the website and refresh themselves. They can have advantage of looking at these presentations. Also, what we have is that these presentations are live on YouTube, so that those who are unable to join here, they can join on the YouTube. And we have about 150 people who have joined on the YouTube. That's a remarkable success of the Navigate program. And although it is a very narrow specialty for all the PGs, but still it's quite a success. With these few words, Anuji and Dr. Padmaji, I again welcome you to join this Navigate program. Thank you very much. Over to you, Dr. Preeti. Thank you very much.
Thank you, sir. Now I'd like to introduce the speaker for today's session, Dr. Anu Gupta, who is an assistant professor in the Department of Neurology at AIIMS, New Delhi. And her research interest includes cognitive neurology and dementia, and she has more than 70 PubMed index publications. It's an honor to have you here, ma'am. Over to you, ma'am.
At the very outset, I would like to thank the NAMS, the organizing team, all the senior faculty members, Dr. Preeti and Professor Padma for this initiative. And I would also like to congratulate NAMS for this excellent program. So I will share my screen. I think, Dr. Preeti, you'll have to stop sharing from your side.
Ma'am, we are not sharing the screen right now.
Okay.
We'll be able to share it.
Yes, ma'am. Now it's being clear.
Okay.
Yes.
So welcome to all the students who have joined for this talk today. So the talk is on clinical approach to dementia. Dementia is a little complex topic, but I think it is important to understand the basics because India is transitioning into an aging population. So in the future, we are likely to have more and more people with these problems. And Indian literature somehow also shows that dementia is not only seen in the elderly, but in our younger population as well. So the aim of today's lecture will be to deliver the basic aspects related to the clinical approach to dementia. So what is the literal meaning of the term dementia? The term dementia literally means undoing of the mind. And as with other diseases, it has a definition with some components to it. So all these components are important and I have highlighted them so that you can understand when do we diagnose somebody with dementia. So dementia is an acquired decline of one's cognitive abilities. It is an objective decline, and the decline should be sufficient enough to interfere with the person's independence in daily activities. The syndrome is not attributable to an acute confusional state or to a major psychiatric illness. So different societies have proposed different formal diagnostic criteria for dementia. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition in 2013, also proposed an alternative terminology for this syndrome, labeling it as a major neurocognitive disorder. So let us go through these components one by one. As I said, it is an acquired decline of cognitive abilities. By acquired, we mean that somebody who had a normal cognition to begin with, later on goes on to develop these cognitive symptoms related to cognitive dysfunction or cognitive impairment. What are these cognitive symptoms or domains pertaining to which the person may develop dysfunction or impairment? So there are broadly 6 domains of cognitive function. The first is learning and memory, wherein the patient may face problems with short-term memory, with episodic memory, or with remote long-term memories. So these people may need to make lists more often. They may misplace objects. They may repeat self frequently during a conversation. They may forget the details of the recent events experienced by them. They may forget prospective appointments, or they may even forget past personal events depending upon the stage of the disease or the syndrome one is dealing with. There may be problems with complex attention, as in difficulty in concentrating while reading, following a movie plot, maintaining the train of thought, just recalling why one entered the room, or having frequent slips in everyday action. There may be problems with executive functions. Executive function is nothing but all that is involved in goal-directed behavior. So it includes motivation, planning, sequencing, and avoiding distractions. So people who have executive dysfunction will have difficulty doing multitasking, or they may have difficulty doing a task which involves multiple steps. So these difficulties may be apparent while using appliances or gadgets, planning an outing or a program, or sorting out the office work, balancing one's checkbook, or playing card games. Other patients may present with behavioral issues or problems with social cognition, where they may fail to take others' feelings into account, make inappropriate comments, have loss of manners or decorum, lack of warmth or empathy. For example, if somebody is sick in the family, they may no longer worry, may no longer care for that person. They may become completely amotivated even for their basic routine, which is known as an apathetic state. They may show repetitive behaviors like clapping, motor activities, repeated use of washrooms, folding, unfolding clothes, packing, unpacking, or they may even develop aggressive behavior. There may be problems related to perception of the space around them. So they may have difficulty in negotiating familiar ways, the ways which were known to them or which they were familiar to. They may have difficulty in recognizing landmarks, recognizing common daily use objects, recognizing faces of the people they know, difficulty finding objects in a clutter, or reaching out to objects in space. And this happens despite normal elementary vision. There may be problems with language, where there may be word finding difficulties. They may substitute wrong words, use wrong grammar, they may have difficulty understanding words, difficulty following oral or written instructions, or a change in the ability to spell words. So when we take the history of a patient with cognitive impairment, we need to tap all these cognitive domains and ask all these questions. So the second step is to document an objective decline in cognitive function and to see whether it is sufficient to interfere with the daily activities. Excuse me. So to document the cognitive dysfunction, we need to do a neurocognitive examination. For neurocognitive examination, we have screening tests, we have detailed neuropsychological batteries, we can do a bedside testing, which is usually done by the residents. And while choosing a cognitive test, one needs to keep in mind the background education of the patient, the language which the patient is well versed with, and the cultural background. So we have some screening tests. The most commonly used screening tests globally are the Mini Mental Status Examination or MMSE and the Montreal Cognitive Assessment Scale. So these tests have their own cutoffs which will define dementia. The problem with the Mini Mental State Examination is that this test may miss mild dementia or may miss patients who have predominant executive dysfunction. So keeping this in mind, the Montreal Cognitive Assessment Scale was discovered. The Montreal Cognitive Assessment Scale was developed to overcome these problems. So it is more sensitive to detect a milder impairment, also screens attention and executive functions better. And there is a provision for lower education. So you can add 1 point to the score. So this is how the MMSE looks like. You need to ask the orientation to time, orientation to place. You ask the patient to repeat 3 words. You may ask him to subtract 7 from 100 serially or spell world backwards. That will be basically testing his attention. Then you can ask him, after giving this distraction, you can ask him to recall the 3 words which the person had previously repeated. This is followed by language testing, where you ask to name, repetition, follow a 3-step command, obey a written command, write down a sentence, and finally copying. So you get a score out of 30 and a score less than 24 may be suggestive of dementia. This is how the Montreal cognitive assessment looks like. So you start with joining a trail of alternative numbers and alphabets, followed by a cube drawing, a clock drawing, and so on. Addenbrook's Cognitive Examination 3 is another commonly used test globally, although it takes more time to administer as compared to MMSE and MOCA. It takes nearly half an hour to administer, but the advantage of this test is that it gives a more representative evaluation of the global cognition and domain-wise functions. So if we do not have time to administer a detailed neuropsychological battery, the patient is not cooperative. So short of everything, we may do an Addenbrook's Cognitive Examination 3. So it will cover different domains like attention, memory, fluency, language, then visuospatial functions, and then again, delayed recall. And in the end, it will give a total score and a domain-wise scoring. So next is how to assess the activities of daily living. So there are two types of activities of daily living, instrumental and basic. The instrumental activities include managing finances, taking one's own medication, independently shopping, housekeeping, cooking a simple meal, or using public transport. While the basic activities include dressing, eating, toileting, grooming. We know that, as I already mentioned, that to label somebody as dementia, the activities of daily living have to be impaired. So initially, it is the instrumental activities of daily living that are impaired. Basic activities basic activities are involved as the dementia progresses to the moderate stage. And we also need to make sure that the activities of daily living are hampered by the cognitive dysfunction and not by the physical disability of the patient due to, say, arthritis or some impaired mobility or poor vision or poor hearing. So these things also need to be taken into account before deciding whether somebody is functionally impaired or not. Then we have tools to assess the dementia severity, wherein based on the informant history and our examination findings, we can grade the patient into mild, moderate, severe. So the next step is to make sure that this cognitive impairment is not due to an acute confusional state or some major psychiatric disorder. So that brings us to the dementia mimickers. So the first mimicker would be delirium. What is delirium? Delirium is an acute disturbance in the person's attention and orientation. So it is acute, it develops over hours or a day or two, and it lasts for a few days. These patients have prominent fluctuations. They may become worse in the evening. They are not comatose, and their state may be hyperactive, hypoactive, or mixed. They may lapse into drowsiness. They may have asterixis or flaps on examination. There may be a suggestion of autonomic overactivity, and these patients may exhibit frank psychosis with hallucinations. There are some practical implications to a patient who has delirium in the context of dementia. Number one, delirium may be the differential of a rapidly progressive dementia. Number two, it may be the first presentation of a neurodegenerative dementia like dementia with Lewy bodies. If the delirium persists for months, it could actually be a dementia which has been declouded. And delirium can rapidly worsen a person who has an existing dementia. The next common mimicker is depression. So an important difference between a patient who has depression and cognitive impairment and a patient who has dementia and cognitive impairment is that dementia patients usually lose insight, at least partially. So they are not forthcoming with their symptomatology until with the symptomatology if the stage is if it is not a mild dementia. Only in the mild stage they may come up with symptoms. On the other hand, a patient with depression will provide a rich and detailed account of his memory problems. There may be frequent sighing and crying, exhibition of loss of energy, They may have agitation with pacing. They may also develop firm and fixed false beliefs known as delusions, persecutory delusions, wherein they may believe that somebody is going to harm them. They may have anxiety related to illness or hypochondriasis. And importantly, there may be a history of depression in the past or depression in the family. Once we do the cognitive examination, it may show deficits, but the deficits are likely to improve with reassurance and motivation. An important catch to be remembered here is that depression may also be the presenting feature of a dementia syndrome. So especially if there are atypical features, if it is starting at an older age, one needs to follow up the patient to see whether this was actually a prodromal presentation. So I told you about dementia and major neurocognitive disorder. This brings us to another terminology, mild neurocognitive disorder or mild cognitive impairment. The mild cognitive impairment is a stage prior to the stage of dementia, wherein the evidence of cognitive decline on history or on testing is at the best modest. The most important feature which differentiates MCI from dementia is the instrumental activities of daily living. In a patient with dementia, the instrumental activities of daily living are affected, but in a patient with MCI, these activities are preserved. This is an important stage because it's a continuum of decline. 10 to 15% of patients of MCI may switch on to dementia every year. So, the pathological changes in the brain may begin a decade or two before the symptoms start. That is the preclinical phase. Then the patient starts showing some cognitive symptoms where objectively also you are able to demonstrate some deficits, but the functional activities are preserved. That is the stage of MCI. Once the instrumental activities also get affected, the patient lands into dementia, and then dementia may be further mild, moderate, and severe. So the key goals or steps in the clinical evaluation of such a patient would be to first establish whether dementia is present and rule out mimickers. Then characterize what are the areas of impaired cognition. What is the syndrome that I am dealing with? What were the presenting symptoms of the patient? How did they start? How have they progressed? And how severe they are now? Are there any functional consequences of the impairment which the patient is having? And then what is the etiology? So if we look at the etiological differential diagnosis, the two broad categories would be neurodegenerative and potentially reversible. So this would be the first important bifurcation when we are working up a patient of dementia. Am I looking at a potentially reversible cause, or it is a neurodegenerative disease? So what are the potentially reversible causes of dementia? So reversible causes can be remembered by the mnemonic dementias. D, depression, drugs. Endocrine causes, metabolic causes like encephalopathy, which may mimic dementia, or neurometabolic, other metabolic disorders like Wilson's disease, epilepsy, nutritional causes, normal pressure hydrocephalus, toxic causes, infections, inflammatory disorders, autoimmune paraneoplastic encephalitis. Autoimmune paraneoplastic encephalitis is a recent upcoming disease which is very important to rule out. We have more and more antibodies coming up for these diseases, for this entity. Structural causes like subdural hematoma and tumors. And I mentioned normal pressure hydrocephalus. Normal pressure hydrocephalus is basically hydrocephalus without features of raised intracranial pressure. These patients present with a triad of symptoms: dementia, gait change, and urinary incontinence. But they do not have features of raised intracranial pressure like headaches, vomitings, and so on. The degenerative dementias could be classified based on the age of onset, whether it's an adult onset disease or a childhood onset disease. In the adults, common diseases include Alzheimer's, frontotemporal lobar degeneration, Lewy body dementias, vascular dementia, and at a relatively younger age, we may have genetic causes like Huntington's, hereditary ataxias, or neuroinflammatory disorders like multiple sclerosis. In childhood, we may be dealing with a metabolic cause like a leukodystrophy, lysosomal storage disorder, a mitochondrial disease, a progressive myoclonic epilepsy, then neurodegenerations with brain iron accumulations, again hereditary ataxias, and so on. So how to go about this differential diagnosis? We need to ask ourselves a set of few questions. The first question is it young onset dementia? Why do we need to know that? By dementia at a young age, by young age, we mean dementias which start before 65, onset before 65 are young onset dementias, and the ones which present in their 20s or 30s are still younger. So patients who present with dementia at a young age are more likely to have neurometabolic disorders as the underlying etiology, or some genetic cause, or some other treatable cause like a demyelination, infection, inflammation, or an autoimmune disease. Neurodegenerative and cerebrovascular disorders are more likely to happen at an older age. The next question is it a dementia plus syndrome? What do we mean by a dementia plus syndrome? So we mean to ask if this dementia is associated with other neurological features. For example, is there an associated ataxia, which may point to a prion disease? Prion is a slow virus disease and is one of the cause of rapidly progressive dementias. Or it may be, ataxia may be seen in a paraneoplastic cause, where a paraneoplastic cause is a condition which is associated with a tumor in the body, and the patient may manifest with a paraneoplastic neurological syndrome. Or it may be a hereditary ataxia. If the patient has some kind of hyperkinetic movement disorder like dystonia or chorea, it may be autoimmune encephalitis, Huntington's disease, neurodegeneration with brain iron accumulation, and so on. If there is predominant Parkinsonism and an older age, it may be a Lewy body disease, corticobasal ganglionic degeneration, progressive supranuclear palsy, other FTLD spectrums. Patient may have myoclonus, which may be seen in prion disease, Hashimoto's thyroiditis, autoimmune paraneoplastic diseases. Then there may be a gaze palsy. The gaze palsy may be vertical or horizontal. A vertical gaze palsy could hint towards the presence of Niemann-Pick disease. It's a lysosomal storage disease. And a horizontal gaze palsy could indicate the presence of Gaucher's disease. So picking up these neurological features can help us delineate what kind of etiology we are dealing with. We also need to see the systemic involvement. For example, if the patient has a splenomegaly, it may be a lysosomal storage disease. Hepatic dysfunction, it may be Wilson's. Gastrointestinal dysfunction, it may be Whipple's disease, right? After that, we need to see whether it is rapidly progressive. Because if the dementia is rapidly progressive, by rapidly progressive is onset of the first symptom to the impairment of instrumental ADLs, or to the stage where one can label the person as dementia, if that period is between, usually 1 year is taken as the cutoff. Some literature also mentions 2 years as the cutoff. But if it is within a year, it is rapidly progressive. And rapidly progressive dementias, you are more likely to find a reversible etiology. And it has its own set of differentials, which we'll be discussing. And then we should also check the medications which the patient is using and any history of substance abuse. So let us look at some clinical examples. A 60-year-old male who is a chronic smoker, a past history of coronary artery disease and a posterior circulation stroke, now comes with a 7 days history of gait unsteadiness, tremors, followed by an altered behavior where he is very agitated. So on examination, he is confused, disoriented, ataxic, and he has upgoing planters. Over the course of time, during the ward stay or the hospital stay, the patient lands into a stuporous state. There is no history of fever, no history of seizures. So in a patient who's had a prior stroke and an acute onset neurological deficit, one would one would think that whether this patient is again having a new stroke. And since the patient landed into an encephalopathic stage later on, we would also like to know whether it is some kind of encephalopathy, whether it is related to an infection, an underlying occult infection, or some metabolic cause like an electrolyte imbalance or uremia. So these are his investigations. His MRI brain did not show any infarct. His EEG was not suggestive of any epileptiform discharges. He was having some anemia, and rest of his biochemical investigations were pretty okay, except a low albumin. His urine routine was also normal, chest X-ray was normal, HIV was negative. So since most of the workup related to infection and metabolic causes, the first tier workup was negative, so it was also thought whether it is a rapidly progressive dementia presenting as delirium, and could it be due to some paraneoplastic or atypical CNS infection. So a CSF was done, but the CSF was also normal. This patient's ammonia level came out to be high, and a CT chest abdomen, which was done for a paraneoplastic cause, actually revealed chronic liver disease with portal hypertension. So an ultrasound abdomen had not been done. This was actually hepatic encephalopathy presenting as hyperactive delirium. The only clue was a low serum albumin, and later on that raised ammonia indicated could be an occult liver disease. Then this patient, a 42-year-old male, known hypertensive, chronic smoker, very irregular with his treatment, presents with change in behavior and forgetfulness of 3 months duration. And as per the relatives, the history was more acute in onset. He became apathetic and withdrawn. He was not interacting with relatives and used to forget recent events. But there were some fluctuations in the course. He had some periods of improvement and then worsening. And on examination, his blood pressure was high. He was amotivated, disoriented to time and place, and inattentive. So first of all, an MRI brain was done, whether he has any strategic infarct, which can explain his symptoms. So there were a few old lacunar infarcts, which you can see in the close to the caudate and in the subcortical white matter. His kidney function tests revealed a high serum creatinine and a high urea. His potassium was also high, and his ultrasound revealed bilateral renal stones, which was stag horn calculi on the CT-KUB. His EEG revealed mild slowing. So his blood pressure was very high when he presented. So antihypertensives were started. Before treatment, his orientation was very bad. And the digit span, which is used to check the attention of the patient, so the digit span was low. On asking him to draw a clock, this is what he drew. And he had flaps in the general physical examination. So just controlling his blood pressure, the patient improved within 7 days. His orientation was 5/5 to time and place. His digit span became normal. This is the second clock that he drew. And now you can see there are no flaps. So this was a case of hypoactive delirium, which was mimicking dementia, but the cause was actually something else. Then a 60-year-old male presents with 2 years history of a progressive change in behavior and forgetfulness. And he has some word finding difficulty. Subsequently, the patient develops quadriparesis. There is weakness in all 4 limbs. He has imbalance in the dark, and he also has reduced appetite, weight loss. His occupation is screen printing and dealing with batteries. When this patient is examined, he is found to have mild dementia, and in the systemic examination, there is evidence of myelopathy, neuropathy, and pallor. So he is dementia plus. So his hemoglobin on investigations was found out to be very low. His TLC was also low, and he had a high MCV with macrocytic RBCs in the peripheral smear. His toxic screen was normal, but his B12 levels were borderline. His nerve conduction studies revealed a polyneuropathy, and his visual evoked potentials revealed a prolonged P100 latency. And this was his MRI spine. There is, you can see, these are T2 weighted sagittal sections of the cervicodorsal spine, and there is a longitudinal signal change in the posterior aspect of the spinal cord. And if you look at the axial sections, you can see that this is in the form of an inverted V or a rabbit ear sign. So this patient had B12 deficiency related subacute combined degeneration of the cord, presenting as myeloneuropathy and cognitive dysfunction. A 17-year-old male presents with progressive change in behavior for 3 months, and his school performance starts declining, but he doesn't have any headache, vomiting, seizure, myoclonus. So he's a young patient, short history. Only problem is progressive change in behavior. And this is what his MRI showed. He had multiple neurocystic cerci in the brain. So he was a case of multiple NCC presenting as dementia without any seizures. Then this girl was a 25-year-old girl who had acute onset psychosis followed by an akinetic mute state, and she developed generalized rigidity, seizures, autonomic dysfunction, and some abnormal movements. So she had these perioral dyskinesias. This was her MRI brain. So there are T2 hyperintensities in the medial temporal lobes, and she was positive for anti-NMDA receptor antibodies. So as I told you previously, that nowadays many such antibodies are being discovered, which are leading to the syndrome of autoimmune or paraneoplastic encephalitis, where the patient may present with a neurobehavioral syndrome or cognitive dysfunction, along with other features like extrapyramidal ataxia and so on. So this is an important entity to suspect and diagnose, because the treatment is totally different. These patients require immunotherapy and they respond well. For a female patient who has NMDA, another thing that needs to be looked at is whether she has an ovarian teratoma. These patients have an association with ovarian teratomas. So removal of the teratoma becomes important for the treatment of the patient. And in paraneoplastic etiologies, it is important to search for an occult malignancy. So we also have primary degenerative dementias. I'll be mainly talking about the adult degenerative dementias, which include Alzheimer's, vascular dementia with Lewy bodies, and frontotemporal degeneration. In the Western literature, Alzheimer's is the most common. In the Asian region, after Alzheimer's, vascular dementia has also been found to be quite common. In the younger patients in the 50s, it is frontotemporal dementia, which may be as common as Alzheimer's. And as the age advances, these patients may have a mixture of pathologies in their brain, leading to mixed dementias. So in a patient who has a degenerative dementia, we need to know at what age the disease started, what were the first and predominant symptoms, what has been the disease course and the rate of decline, whether there is associated motor involvement, especially extrapyramidal involvement, and if yes, whether it is symmetrical or asymmetrical. Does the patient have any markers related to abnormalities of sleep, fluctuations in alertness, prominent and early visual hallucinations? These three could be an indicator of an alpha-synuclein pathology, which is seen in Lewy body diseases. So we need to jot down the syndromic diagnosis, whether we are dealing with an amnestic syndrome or a neurobehavioral syndrome or a language disturbance or a visual syndrome or a corticobasal syndrome. A corticobasal syndrome is the one where you have cognitive deficits with asymmetric motor signs. And then we need to decide the etiology. There is a lot of overlap of etiologies and pathologies amongst these clinical syndromes. So the best approach would be to use biomarkers which are related to the pathophysiology of that particular degenerative disease. At present, we have pathophysiological biomarkers for Alzheimer's disease. The pathophysiological biomarkers for others' disease are still in the development phase. So Alzheimer's is the most common cause of dementia worldwide, and it was first proposed or the first reported by Alois Alzheimer, who was a German neuropsychiatrist, and he basically published a case where the woman was a 55-year-old lady, and she presented with some forgetfulness and neuropsychiatric symptoms. So at that time, he found that there are two types of abnormalities or neuropathologies in these brains in the form of amyloid plaques, which has amyloid beta deposition in the core, and neurofibrillary tangles, which is nothing but hyperphosphorylated tau protein. So these pathological changes stand till today, and these are the important pathophysiological biomarkers of Alzheimer's today. So in Alzheimer's, the early feature is loss of, in classical Alzheimer's, I would say the early feature is loss of episodic memories and impaired new learning. And there are risk factors which are non-modifiable, like age, apolipoprotein E polymorphisms, Down syndrome, some genetic mutations. There are some modifiable risk factors like vascular risk factors, hypertension, diabetes, obesity, dyslipidemia, smoking, head injury, depression. And there are certain protective factors which contribute to one's cognitive reserve. These are education, physical activity, following social engagement, and cognitive stimulating activities. So in the typical late onset we mean when it starts after the age of 65. In the typical late onset amnestic Alzheimer's disease, you find hippocampal or medial temporal lobe atrophy. So you can look at the temporal horns, which are quite widened, and the medial temporal lobe or the hippocampal atrophy is quite evident. But at a younger age, Alzheimer's may present as a variant presentation, like posterior cortical atrophy, which is the visual variant of Alzheimer's, wherein the patient may have difficulty in finding or locating objects or faces. So here, the atrophy is more prominent in the posterior regions of the brain, that is the parietal occipital temporal lobes. There are other variants of Alzheimer's. It may present as a language disorder to begin with. It may present as a neurobehavioral syndrome also. So as I told you, for diagnosis, we need to look at the pathophysiological biomarkers. The MRI brain and the FDG PET will tell you that there is neurodegeneration. But the pathophysiology can be revealed by either doing a CSF, which can show you low amyloid beta levels or increased tau levels, or a tau PET or an amyloid PET. So in FDG PET brain, in Alzheimer's, you see parietal and temporal hypometabolism. So the area which is purplish, not blue. The yellow one is the normal uptake. So these are the hypometabolic areas. So there is bilateral parieto-temporal hypometabolism. If you do a tau PET in the same patient, you will see abnormal light up due to tau deposition in these areas. And in the amyloid PET, you will see a diffuse deposition of amyloid. So we also have vascular dementias, where we have different subtypes based on the clinical and radiological findings. For example, if the patient has develops multiple strokes, he may keep on accumulating cognitive deficits stroke by stroke, leading to a stepwise deterioration in his cognition, and this state is known as multi-infarct dementia. On the other hand, he may develop an insidious onset, slowly progressive syndrome, wherein he may also develop a gait disorder, where there are a lot of balance issues, start hesitations, slowness of his thoughts, and slowness of response. That is a subcortical presentation of vascular dementia. Vascular dementia may also present as a strategic infarct, wherein some of the eloquent areas involved in cognition, for example, if somebody has bilateral anterior thalamic infarcts, that area is an important area in the memory circuit. So that patient will develop an acute onset forgetfulness. So that is a strategic infarct. Some of these patients may also have hemorrhagic syndromes, like there may be amyloid deposition in the vessels leading to cerebral amyloid angiopathy in Alzheimer's. Or there may be genetic mutations, which may lead to a diffuse small vessel disease. One of them is CADASIL. or the patient may have an inflammatory disorder like vasculitis. So vascular cognitive impairment has some peculiar features. One is in cognition, there is a slowing, psychomotor slowing. In the motor part, there is an early and prominent gait disorder in 50% patients. And in the associations, there may be a temporal correlation with history of stroke. And you may find other signs like focal signs on examination indicating that there is the evidence of vascular damage. So these are some MRI pictures of vascular cognitive impairment. This is a large cortical infarct. This is diffuse small vessel disease. This is again diffuse small vessel disease along with temporal pole involvement and microbleeds. This picture is typical for hereditary vascular disease or CADSIL. Then these are microbleeds seen in amyloid angiopathy, and sometimes amyloid angiopathy can also have inflammation. Then there are Lewy body dementias, which are of two types: dementia with Lewy body disease or DLBD and Parkinson's disease dementia. These patients have alpha-synuclein or Lewy body depositions in their brain, and they are a common cause in the elderly people. And their crux is they have Parkinsonism and dementia. And how do you separate out DLBD from Parkinson's disease dementia? It is the 1 year rule. So in dementia with Lewy bodies, dementia will either start before Parkinsonism or before the motor features or within an year of the motor symptoms. Whereas in Parkinson's disease, initially for the first few years, the patient only has motor symptoms, and as the disease advances, the patient may develop cognitive symptoms. So dementia with Lewy bodies has certain other core features like a sleep disorder wherein they may enact out dreams, thrash out their limbs, fall from the bed. They may have prominent visual hallucinations. They may have a fluctuating alertness. And you also have certain biomarkers through which you can pick up these dementia with Lewy bodies. For example, there is a SPECT scan known as a TRODAT SPECT, which will pick up dopaminergic dysfunction. So if the patient does not have clinical Parkinsonism, one can do a TRODAT SPECT and see if there is a subclinical evidence of Parkinsonism, right? If there is no history of a sleep disorder, one can do a sleep study and look for the changes. So in dementia with Lewy bodies, the left panel is a patient with dementia with Lewy bodies, wherein you will see a prominent occipital hypometabolism. And on the TRODAT SPECT, as I told you, there is evidence of dopaminergic dysfunction. This is Alzheimer's disease, wherein you have a temporal lobe atrophy. Here, the occipital metabolism is preserved, and you don't have any dopaminergic dysfunction. So Parkinson's disease dementia I already mentioned. Then there's another big group known as the frontotemporal lobar degenerations, which can present as either a language syndrome known as a progressive aphasia or a behavioral syndrome. And this behavioral syndrome can be associated with motor features. So frontotemporal lobar degenerations have many different pathologies. They have different genetic mutations, and there is a lot of clinicopathologic and clinicogenetic heterogeneity. So I'll just mention a few important points. For example, a patient who has behavioral variant frontotemporal dementia, these patients will present with a neurobehavioral syndrome, and they will have frontal and temporal atrophy on their MRI. Patients who present with the language syndrome may lose their fluency. So they may lose their fluency and become agrammatic. So we can listen to this voice recording. This is the voice recording of a patient who had a non-fluent aphasia.
कल आपने सारा दिन क्या किया?
There is decrease in the clarity of speech.
रात में भोजन किया,
On asking about the daily activities, the patient says, Bhojan kiya, aaram kari. So there is, so the fluency, the word output is very less. And he's not able to put it down into a proper sentence with verbs and prepositions and other things. So it's just, it is a very agrammatical and telegraphic kind of speech. So these patients who have non-fluent aphasia have an atrophy in the peri-insular region, wherein the inferior frontal lobe is atrophied on the dominant side, where the language areas are represented. Then there is another type known as the logopenic aphasia. So just listen to this voice recording.
कल आपने
Sorry.
वो बहुत पहले उठ जाते हैं। वो साढ़े मतलब 2 हफ्ते में 2 दिन के लिए वो तो 3:30 बजे उठ जाती हैं, 3:30 बजे। मतलब कौन सा डे है वो? एक तो ये है क्या नाम है, इस मंडे और क्या नाम है ट्यूसडे।
So in a patient who has a logopenic type of aphasia, fluency is reduced, but not as reduced as in a non-fluent aphasia. Grammar is preserved, but the patient has word retrieval difficulty. That is why the patient has to again, time and again say, kya naam hai, kya naam hai. So this is the kind of speech which we see in logopenic aphasias. These patients have atrophy in the posterior temporal region and the corresponding parietal part. So temporoparietal junction again on the dominant side. And the third type is semantic aphasia. Semantic aphasias are the ones where the person loses meaning of words. Semantics are our concepts. So for example, if a doctor were to develop semantic aphasia and you ask what is a stethoscope, describe, or you show a stethoscope, you show that person a stethoscope, the person will say that this is something which has 2 tubes and a long cord and a round thing at the end, but would not be able to say that this is a stethoscope. He may give a funny name to it. So these patients actually lose their concepts. So they lose meaning of words. And here the atrophy is in the anterior temporal region, again on the dominant side. It is a temporal pole atrophy on the dominant side. So out of all these 3 language variants, logopenic is the one which may also present as, or more likely, I would say more likely to have an underlying Alzheimer's pathology. So that has an overlap with Alzheimer's disease. So there are 2 other entities wherein, again under the FTLD spectrum, where you have motor features. One is progressive supranuclear palsy, wherein the patient has Parkinsonism, early falls, and a vertical gaze palsy. There is a vertical gaze palsy and there is midbrain atrophy. You can see the flattening of the surface of the midbrain. So there is midbrain atrophy. That is the syndrome of progressive supranuclear palsy. And some of them have asymmetric motor symptoms. As I mentioned, corticobasal syndromes. So they have asymmetrical cortical atrophy, most prominent in the perirolandic area. And on the opposite side, they will have motor dysfunction. They also have cognitive involvement. So these syndromes are known as corticobasal syndromes. And one of the etiology is corticobasal ganglionic degeneration. So dementias may be rapidly progressive. As I said, when the onset to dementia is within 1 to 2 years, the prototypical cause is prion disease. And most of the large series have revealed either a prion disease or an autoimmune cause, and degenerative causes are also fairly common. This is one series from India. It was reported from PGI Chandigarh, where infections were also found to be one of an important cause of rapidly progressive dementia. So these are some of the representative MRIs in these patients. Patients with prion disease have this cortical ribboning sign, and their basal ganglia may light up. And these changes are more prominent on diffusion weighted images. Then patients with autoimmune encephalitis, or I showed you this MRI, they have asymmetric or maybe symmetrical limbic involvement. Patients with herpes encephalitis may have an asymmetrical temporal lobe involvement. Then a patient who has Wernicke's encephalopathy may have a medial temporal lobe and mammillary body involvement. Somebody who has hepatic encephalopathy may have T1 hyperintensity in the thalamus. Patients who have vascular dementia may have a lot of subcortical white matter changes. This is a left thalamic bleed presenting as rapidly progressive dementia. These are abnormal enhancing vessels in a patient of CNS vasculitis. So neuroimaging has an important role to play in patients who present with a rapidly progressive cognitive syndrome. So there may be some specific EEG patterns. I think two of them you should remember. One is periodic complexes, where you have periodic discharges at short intervals or long intervals. Short interval discharges are seen in prion disease or CJD. Long interval are typical of SSPE. And then there may be other findings which are described, which you can read in your books. There are certain critical issues in the management of these patients, especially the degenerative ones. For example, I would like to mention that patients who have Lewy body dementia, they are very sensitive to antipsychotics. They have a tendency to develop neuroleptic malignant syndrome. So antipsychotics have to be chosen very wisely in these patients. And non-pharmacological interventions, wherein you look for pain, infection, constipation, nutrition, correct the vision and hearing deficits, and provide an adequate social interaction, have their own role. There are prevention strategies mentioned, wherein one needs to increase the cognitive reserve, exercise, reduce the inflammation, and the vascular risk, work on the vascular risk factors. And of late, 2 anti-amyloid drugs have been approved in Alzheimer's disease. One is aducanumab and the second is lecanemab. But further results are still awaited. We don't have any disease-modifying therapies for other neurodegenerative dementias as of now. So I will, if we have time, can I show 3 cases?
Sure, ma'am.
Okay. So I'll just show 3 cases and let us see if we are able to get hold of them. So a 30-year-old male, young patient, has a long history, cognitive decline for 10 years. And he has other neurological features also. So it is a dementia plus. He has gait ataxia, limb ataxia, dysarthria, dysphagia. And there is a family history. Family history, I forgot to mention, very important to take the history of positive similar disease or other neurological disease in the family. So similar illness in 2 elder siblings who died in their 20s. So on examination, the patient is globally impaired cognitively. He has some findings in the cranial nerves. He has ataxia. And in the systemic examination, the spleen is palpable. And this is the video of his gaze. So if you examine the saccade is when you ask the patient to quickly and voluntarily look towards an object. So there is a difference between horizontal and vertical. Horizontal are normal, vertical he is not able to initiate. This is the examination of the pursuit. Pursuit is when we ask him to track the movement of the finger. So his horizontal pursuit is normal. And his vertical pursuit is also normal. So the only abnormality was impaired initiation of vertical saccades, and that was the most important catch in this case. So his bone marrow biopsy revealed foamy macrophages and foamy cells. This was a case of lysosomal storage disease, Niemann-Pick C. So if you remember that table, dementia plus vertical gaze, Niemann-Pick C. So that was an important clue in this case. A 42-year-old female presents with executive dysfunction and some behavioral change. Also has a stroke. And with this stroke, she worsens further. And the gait changes. She has imbalance, she is slow, she has difficulty starting her gait, and she has a lot of emotional lability. There is a family history of young strokes. So this patient had diffuse white matter disease, involvement of the temporal poles. You can see here, temporal poles and microbleed. So this was a case of CADICIL. A 42-year-old male, 2 years history of progressive cognitive decline and spastic quadriparesis. This patient was addicted to certain drugs and he returned from the Middle East. And this was the MRI. So you can see T2 weighted hyperintensities involving the parieto-occipital white matter and the splenium of the corpus callosum. And these hyperintensities are extending along the pyramidal tracts. They are extending along the pyramidal tracts. And the spine shows some atrophy. So this patient had a positive family history. His sister's son had proven adrenoleukodystrophy. This was the late presentation of an X-linked adrenoleukodystrophy. His genetic test was positive for the ABCD1 gene mutation. So the key messages that I would like to give is always remember the components of the definition. Acquired cognitive deficits, objective deficit, impairs ADLs, and not explained by delirium, not explained by a major psychiatric disorder. We need to see whether it is a mild involvement or actually fitting into the criteria of dementia. We also need to rule out reversible causes. Degenerative dementias, important is to look at the early deficits, how the patient presented. That is going to give you a clue towards the syndrome and the likely etiology. So thorough history is the first critical step. Delirium can mimic a rapidly progressive dementia. Fluctuations can be seen not only in delirium, but in patients who have epilepsy, who have vascular causes, who have neurometabolic causes, and amongst the degenerative dementias, they are a feature of dementia with Lewy bodies. If you look at the age, the time frame of decline, and the associated features, dementia plus features, they will help you narrow down your differential. You should also take the history of sleep disorders, the family history, and look at the comorbidities of the patient. Always look at the drug list or any over-the-counter medications which the patient is taking. And don't forget the importance of non-pharmacological interventions. With this, I thank the audience for their attention, and any questions, I would be happy to answer.
Till the audience start asking questions, I have one doubt, ma'am. In patients with depression along with cognitive deficits, sometimes we have difficulty in differentiating whether it is because of depression, whether it is pseudo-dementia or it is dementia. Like the strategy which we follow till now is that we first treat the depression, then once it improves the remaining cognitive deficit, then we attribute it to dementia. What is your suggestion, ma'am? Should we start treating dementia together along with depression, or should we first treat a depression and then go for treatment of dementia?
So I think the approach you are following is the one which we also do. We do take a psychiatry and neuropsychiatry opinion in these patients once we are suspecting pseudodementia. In case these patients do not improve, we go for an FDG PET scan to see if there is any hypometabolism which could be suggestive of a prodromal depression as a prodromal symptom of dementia.
Hello, can you hear me?
Yes, please. Dr. Amal, please go ahead.
Yes, you know, my wife, now she is 73 years old, and about 5 months earlier, she has started developing this dementia. And at this stage, it is very rapidly progressing. You know, when 10 minutes earlier, what she talked or what she has seen, she cannot remember. That's the main area of trouble. Otherwise, you know, she's active, she can speak. There is no problem in the motor movement and all the things. But only thing, she forgets what is happening. And she keeps on asking the same question that, you know, what has happened, you know, and want us to keep on answering her. So how do we go about for, you know, as far as any medication is concerned, you know, what is the procedure of this?
So, sir, first thing would be whether her functional activities are impaired or not. So, if her functional activities, the instrumental activities like managing the home, preparing a simple meal, managing the finances, or other such activities which she used to do before, if she is still capable of doing independently, then it would be a stage of mild cognitive impairment. If these
No,
are
she
affected,
cannot do that.
if she cannot do that, then she needs to be investigated for dementia. And if the history is short, she needs to undergo an imaging and other blood tests and a cognitive examination to see what the actual etiology is. Because treatment will be as per the etiology. We first need to see whether it's a reversible cause or a degenerative syndrome which has begun to develop.
Thank you.
Madam, how early CBT helps in these patients?
You mean cognitive behavioral therapy?
Yeah.
So cognitive behavioral therapy as such will not help patients who have frank dementia. That is mainly for psychiatric disorders like depression.
In continuation of this, what should we advise a patient in terms of cognitive rehabilitation if we find a person is having dementia?
So cognitive rehabilitation strategies will depend upon the stage of dementia and also on the type of deficits which the patient is having. In moderate and severe stages, the rehabilitation strategy is more towards preventing harm to the patient, lessening caregiver burden. While in the early stages, especially in the mild cognitive stage, there are other options which are available. So we ask patients to engage in cognitively stimulating activities to start reliving their interests and hobbies, engage in meaningful work, and also continue with some kind of physical activity under supervision. So all these things are known to help in reducing the progression of dementia. Another important aspect that needs to be taken care of is an undetected vision loss or hearing loss. So if somebody has an undetected vision loss or hearing loss, that can accelerate the progression of dementia. So that also needs to be taken care of.
Thank you. There's one question in the chat, ma'am. In case of a patient, say 24 years of age, presenting with past history of poor scholastic performance with no regression, should we include MOCA or MMSC for cognitive testing or any low bar testing?
So in a patient in whom you are suspecting intellectual disability, the history is there from the beginning. It would be MMSC or MOCA may not be appropriate tests. There are specific tests to look for specific kind of disabilities and the intellectual level. So that is the assessment goes in totally different direction in such cases.
What will be the best way for psychiatric evaluation in such patients? Early dementias, where we have got Parkinson's plus minus, where it is difficult to differentiate clinically.
So you're talking about the cognitive examination?
Yeah.
So cognitive examination, if we see, so we take an example of dementia with Parkinsonism. Dementia with Parkinsonism could be dementia with Lewy bodies, progressive supranuclear palsy, vascular, corticobasal degeneration. So most of these may have similar deficits on cognitive testing related to executive dysfunction, apathy, inattention. Some of them, for example, patients who have corticobasal ganglionic degeneration may show signs of asymmetric lobar involvement in terms of parietal lobe involvement. So that is one clue which can guide you towards the etiology. Otherwise, in general, just on the basis of cognitive testing, it is difficult to dissect out these syndromes individually. So the differential will be based upon the associated findings. What are the findings on motor examination? Are they symmetrical, asymmetrical? Are there any vascular risk factors? Has had the patient a stroke? What are the MRI findings? Are there any gaze palsies? So all these things need to be taken into account. Purely on the basis of a cognitive examination, it is difficult to differentiate.
The neuroimaging will help to some extent in the early stages. That's
yes. Neuroimaging is going to help, as I showed. In PSP, you may get the midbrain atrophy, which is with preserved belly of the pons, known as the hummingbird sign. In vascular diseases, you may get extensive evidence of extensive vascular involvement. Then in corticobasal degeneration, you may have an asymmetric perirolandic atrophy. So these imaging markers need to be looked for, and they are helpful.
Holistic approach for early management, anything is, you have got a data for that, supporting early recovery, yoga, meditation, holistic
Pardon?
approaches.
Could you
The
repeat
holistic approach for early recovery treatment aspect.
Mm-hmm.
Is there any data to suggest?
So these things do help in the early stages, particularly the mild cognitive impairment stage. As once the dementia progresses to a moderate to severe stage, how much benefit these things are going to give is a little difficult, and these patients may not even follow these protocols. But yes, in the early stages, these things do help in delaying the progression of the disease. And they also help in the physical activity, and all these aspects also help in bringing down the behavioral symptoms of dementia.
I think there are no more questions. Would you like to give some take-home messages for the audience, sir? I think there are no more questions. Should we conclude, or would you like to give some take-home messages or ask questions from the audience?
I think the take-home message is that in the history is very important. It is important to take it in all details, how the symptoms started, what all symptoms are there, tap all the cognitive domains, look at the associated features, look at the time frame over which the illness has developed. And that is probably going to guide you whether dementia is present or not, and if yes, what is the etiology.
Thank you so much.
Does this artificial intelligence is going to help you in early stages? Any data is there?
So artificial intelligence is also upcoming. People are looking at eye tracking movements. People are looking at voice modulations, gait changes. So it is an upcoming field. We don't have clinical solutions as of yet.
Thank you so much, ma'am. It was a wonderful presentation. I would now like to invite Professor Ajay Kumar Sood sir to provide the vote of thanks.
Thank you so much on behalf of the National Academy of Medical Sciences. It is my privilege to thank the esteemed speaker for this evening, Dr. Anu Gupta, for covering this comprehensive topic of dementia in a very simple way. He has given case examples, audio and video clippings, and I'm sure, Madam, our participants, especially the PG students, have greatly benefited out of this. We are really grateful to you, and we look forward for your support and blessing to National Academy in future also. Thank you so much. I will also like to place on record the support which we have been getting from the chief coordinator for this series on neurology, Madam Professor Dr. Padma Shrivastava ma'am. She has identified the topics as well as the speakers. So we are really grateful to her for the support to the Academy. Again, we'd like to place on record the support which we have been getting from Dr. Preeti. She has been kind enough to be with us throughout the series, right from the beginning when we started in January and moderating the session. We express our thanks to all the participants who have joined us this evening, and they have asked a question that has made this session more interactive and interesting for all of us. Again, I would like to inform the participants, especially the PG student, that the next session for the series on neurology is on 20th of July. And this again is going to be a very interesting topic of a stroke, which we are going to cover. But before that, on this coming Saturday, on 15th of July, we have another session on management of rheumatoid arthritis by a very esteemed speaker from All India Institute of Medical Sciences. So please do remember that this Saturday we have a session, so please join. And I will also like to place on record the support which we have been getting from our IT team, Mr. Ravi and Mr. Anil, who have been helping us in the background for organizing the transmission Zoom as well as on the YouTube. So once again, I would like to thank all of you who have joined us this evening and made this evening very interesting for us. Over to you, Dr. Preeti.
Thank you, sir. Thank you, everyone. I declare today's academic session closed.